Hello, my name's Dr. Ayesha Jameel. I'm a Clinical Research Fellow at Imperial College London, and I'll be presenting our team's work on the evolution of VIM targeting, an international perspective from 2019 to 2021. The ventral intermediate nucleus, or VIM, is the premier site for MR-guided focused ultrasound ablation in the treatment of tremor. It cannot be directly visualised on current clinical scanners, and therefore there's much debate on the best way to target the VIM. Inaccurate targeting risks adverse sensory or motor effects. There are two methods to infer VIM position: anatomical, using adjacent landmarks, or tractography, using diffusion tensor imaging, but there is no current consensus on the best way to target the VIM. We first noted the various approaches to targeting the VIM at a 2019 FUS conference in Barcelona. Shortly afterwards, we commenced the Is My VIM Your VIM study, but was unfortunately halted by the COVID pandemic. In 2021, the FAS Foundation Global Summer Scholar Senna Atkin joined our team and reinvigorated the project, and these results we'll be presenting today. The aims of the study are to assess the various VIM targeting approaches, VIM-TAs, used internationally in MR-guided focused ultrasound thalamotomy for the treatment of tremor, and to ascertain any trends in the VIM-TAs between 2019 and 2021. All centres on the Insight Tech Focused Ultrasound database were invited to participate and share their VIM targeting approach for 2019 and 2021. Results were analysed with particular regard to their primary targeting method, any anatomical landmarks utilised, and the utilisation of tractography. All centres' VIM-TAs were mapped graphically in relation to the mid-commissural point and on a 3D model of the thalamus based on the Shasbergen-Warren atlas. Any trends or evolution in VIM targeting across the study period was ascertained. 3D model of the thalamus was created based on brain 77 of the Shasbergen-Warren atlas. Key nuclei were segmented, including the VIM and the ventral oralis posterior, or VOP, and the ventral caudalis, or VC. Brain 77 was a small female brain with an ACPC length of 23 mm. The model was scaled up to be more representative of a modern brain, with an ACPC length of 27.8 mm. This was the average of our last 30 FUS patients. In total, 30 centres participated in the study, 26 centres in 2019 and 23 centres in 2021. In both years, the primary method of targeting was anatomical, with approximately 96% of centres targeting this way. In both years, in the anterior-posterior plane, the AP coordinates range from -3.5 to -7.9 mm posterior to the MCP. For both years, the vast majority, greater than 70% of centres, targeted VIM between -6 and -6.9 mm posterior to MCP. Overall, the distribution of the AP positions remained stable across the study period, as you can see in both graphs. The distribution of the medial lateral coordinates also remained stable across the study period. These range from 11.1 in 2019 and 11.4 in 2021 to 18.6 in both years, millimetres lateral to the MCP. However, in the superior-inferior plane, there was a notable trend, with many centres moving to target the VIM 2 mm above the MCP. In 2019, only 16% of centres targeted here. In 2021, 40.9% of centres were targeting 2 mm above the MCP. This superior evolution in VIM targeting is well demonstrated on this graph. At the level of the green arrow, which is 2 mm above the ACPC line, you can see that there were 4 centres in blue targeting in 2019. However, this increased to 9 centres in orange targeting in 2021. Here is the 3D model of the thalamus created from the Shasbergen-Warren atlas. You can see the VIM has been segmented in dark green, the VOP in dark grey, and the VC in light grey. In the final video, you can see the VIM demonstrated alone, and you can see its inferior borders tapering. Here are the 2019 centres mapped onto the model with representative views in the sagittal and axial planes. You can see in the anterior-posterior direction there is a wide spread, with many centres clustered at the VIM-VC junction or at the VC itself. There is also a wide spread in the medial lateral plane, best demonstrated on the axial view. Here are the 2021 centres mapped onto the model with sagittal and axial views. Again, you can see a similar distribution in the anterior-posterior and medial lateral planes. And here the centres for both years are mapped onto the model, and you can see there's an increased activity at the 2 mm mark. The best representation of this is the imperial targets, which lie anteriorly within the VIM in green. The inferior target is at the ACPC line, and this is Imperial's 2019 target. In 2021, we moved up superiorly to the 2mm mark and are one of the 9 centres who target there. From 2019 to 2021, we noted this evolution in VIM targeting internationally and independently, with many centres now targeting the VIM 2mm above the MCP, a total of 40.9% of centres targeting here. There has also been increased adoption of tractography over the study period. Although only one centre uses tractography as its primary method to target the VIM, many centres utilise tractography in conjunction or as an adjunct to anatomical targeting. In 2019, only 30.7% of centres were utilising tractography in some form, but this doubled to 60.8% of centres in 2021. Similar patterns have seen in the research field as well. Why is this superior trend happening? We can only speak of Imperial's experience. We have moved to target the VIM 2mm superior to the ACPC line. We find that we get good distal tremor control here, but we also perform a double lesion thalamotomy. We target the PSA 1mm inferior to the ACPC line, and here we get good proximal tremor control. We are also incorporating tractography into our practice, but this is mostly in the research sphere. Given this international trend to target more superiorly, we presume that all centres are tailoring their treatment because they're getting better clinical outcomes and perhaps fewer adverse effects. If this is a true evolution, how much more superiorly will we go? And when do centres start to move more superiorly within their practice? There is also a wide distribution in the anterior-posterior plane. The Shatterbrand-Warren Atlas displays these centres targeting at the VIM-VC junction and all within the VC itself. However, centres report good tremor control, and some centres report some sensory adverse effects, but there is certainly much to explore here. COVID-19 paused our original study and made it harder to engage with centres to get complete dataset. It also stopped centres doing non-emergency work, and therefore any natural evolution in VIM targeting may have been affected. However, we were able to get 2 time points, and this allowed us to see this trend, and, in some ways, our study itself evolved. The accuracy of mapping was heavily reliant on the accuracy of the Shatterbrand-Warren Atlas, which was based on a single female brain with an ACPC length of 23mm. The macroscopic dissections of the Shatterbrand-Warren Atlas were performed along Ride's plane, which is slightly different to the ACPC plane used in modern imaging. Furthermore, there's a lack of consensus in thalamic nuclei and tremor targets, with a multitude of thalamic atlases. It would be interesting to overlay our centre's responses to different atlases and see whether they correspond to a motor or sensory nucleus. Perhaps high field strength modern day scanners can help provide a solution of where's best to target the VIM. Future research could correlate the superior and inferior target locations with clinical outcomes and adverse effects, and consider similar analysis in the anterior, posterior and medial lateral planes. 7T imaging can directly visualise the VIM, and we're undertaking studies to confirm our target locations on 7 Tesla imaging. We would like to explore the various tractography techniques used internationally to delineate the VIM, and assess the utility and challenges of tractography-based targeting. We are embarking on a new study entitled The Evolution of Tractography in Focused Ultrasound. In conclusion, this study demonstrated that the vast majority of centres use anatomical targeting, although more centres are adopting tractography into their practice. The VIM targeting approach was stable in the anterior, posterior and medial lateral planes across the study period, but there was a definite evolution to target more superiorly from 2019 to 2021, with 40.9% of centres now targeting 2mm above the ACPC plane. And finally, this study showed that collaboration is a wonderful thing. We would like to thank all centres who participated in the study, listed here, the Focused Ultrasound Foundation for their Global Summer Scholarship Scheme, and Paul Ragg from Insight Tech for the database. Thank you for listening on behalf of our Focused Ultrasound team. Please do visit us in London.